Hello, and welcome to the SimpleMed Paediatric Lecture Series. My name is Dr. Harriet Morris, and I am the Paediatric Lead. Today's lecture will be on the development of the GI tract and common conditions relating to abnormal development. This lecture is aimed at preclinical or Phase 1 medical students and allied healthcare professionals, and so it is pitched at that level. Our learning objectives today are to recall the normal embryological development of the gastrointestinal system, to be able to link common neonatal and paediatric GI conditions to abnormal embryological development, and to understand symptoms and management for 5 paediatric GI conditions. This includes omphalocele, gastroschisis, Hirschsprung's disease, Meckel's diverticulum, and myrotation disorders. I'd like to start this lecture by explaining how an embryo normally forms and matures, beginning with fertilization. Fertilization is when a sperm cell fuses with an egg cell and their genetic material combines. In the first weeks following this, the early embryo undergoes cell division and forms the multicellular structure called a blastocyst, which implants itself into the uterine wall. In the third week of gestation, the blastocyst undergoes gastrulation, whereby cells start organizing and differentiating into separate layers, forming an important structure called the trilaminar disc. This is composed of 3 germ layers: the ectoderm, this goes on to form the skin; mesoderm, forming the musculoskeletal and circulatory system; and endoderm, important for our talk today as this forms the lining of the GI tract. After week 3, the embryo starts to fold in 2 planes, the sagittal and the transverse plane, to form a tube structure known as the primitive gut. This is lined by endoderm and connected to the yolk sac by the vitelline duct. The yolk sac is where the embryo at this stage gains its nutrition. Eventually, by week 8, the way the embryo folds leads to the obliteration of the vitelline duct, enabling the fetus to gain its nutrition now solely from the placenta via the umbilical cord. This diagram shows the embryo with its umbilical cord, vitelline duct remnant, and the primitive gut tube. We can divide the primitive gut tube into 3 parts, according to the arteries, nerves, and veins that supply each part. The foregut gives rise to the esophagus down to the proximal duodenum and is supplied by the celiac artery. The midgut forms from the proximal duodenum up to 2/3 along the transverse colon, supplied by the superior mesenteric artery. And finally, the hindgut develops into the remaining sections of the GI tract, from the final third of the transverse colon down to the rectum. As we can see on this diagram, the midgut has pushed its way into the umbilical cord. This is known as midgut herniation and will be discussed on the next slide. Midgut herniation occurs during the 6th week of gestation. It happens because as the midgut grows and develops, it doesn't have any room to do so within the confines of the embryo itself. Therefore, the midgut has to push its way into the umbilical cord to allow it to grow even more. Whilst it resides in the umbilical cord, the midgut tube rotates and twists on itself in an anti-clockwise direction. By week 11, the abdominal cavity is large enough for the midgut to return to it, turning a full 270 degrees anti-clockwise as it does so. This turning places the ascending colon to the right of the growing small intestine. As part of our basic overview of embryological development, it is important to mention the formation of the nervous system that supplies the gut, known as the enteric nervous system. Primitive nerve cells, called neural crest cells, are found in the notochord, a structure located in the mesoderm of the trilaminar disc. These primitive nerve cells migrate down the gut tube to form the submucosal and myenteric plexus. The submucosal plexus is mainly responsible for controlling blood flow and absorption of nutrients from the gut lumen, whereas the main function of the myenteric plexus is the movement of the gastrointestinal tract This movement is known as peristalsis. It's really useful to apply the knowledge we've just learnt to conditions that you might come across in your future hospital placements. I'd like to start by saying that there are extra challenges when diagnosing gastrointestinal conditions in children, because often symptoms children present with are vague or misleading. For example, depending on their age, a child might present to a doctor with symptoms such as irritability, failure to gain weight, fever, vomiting or diarrhea, and it can be caused by a multitude of conditions, such as the ones we can see here. To make it easier to remember all of these conditions, it's good practice to organise them into groups by what age they commonly present at. Although, as you can see from the list here, there is often a lot of overlap. The conditions I've highlighted we'll be discussing during this presentation. Therefore, we are mainly focusing on neonatal gastrointestinal complications. I'd like to begin by explaining the conditions omphalocele and gastroschisis. These are issues that arise due to abnormalities in the stage of development where midgut herniation occurs. An omphalocele forms when the midgut fails to return to the abdominal cavity by week 11 of gestation. Therefore, the small intestine remains outside of the abdomen when the baby is born. It can be associated with developmental disorders. Therefore, if omphalocele is picked up during an antenatal scan, further testing for chromosomal abnormalities should be discussed with the mother. Gastroschisis occurs because the abdominal wall fails to close after the midgut has returned to the abdominal cavity. Therefore, the bowel contents herniates through this defect, and it is not protected by peritoneum either. Therefore, swift surgical management is required to reduce the risk of infection, fluid loss, and ischemia once the baby is born. For both these conditions, neonates require fluid resuscitation and transferring to a neonatal unit, usually at a tertiary centre, for surgical reduction of the abdominal contents. If a neonate is seen with a distended abdomen, constipation, failure to thrive, or a history of not passing meconium within the first 24 hours of life, Hirschsprung's disease should be considered as a diagnosis. In Hirschsprung's disease, neural crest cells, those primitive nerve cells that we discussed before, fail to migrate down the length of the gut tube during development. This leads to absence of myenteric and submucosal plexus in the distal bowel, and therefore peristalsis is impaired, and the stool is unable to pass through the bowel properly. Sometimes the entire length of the colon is affected, and this is called total colonic aganglionosis. A definitive diagnosis is made by taking a biopsy sample of the rectum and visualizing this tissue underneath a microscope. Management of Hirschsprung's disease usually requires removal of the affected bowel. This is called a pull-through operation, as the proximal healthy bowel is reconnected to the anus. As we've previously discussed, the vitelline duct is a tract that connects the midgut to the yolk sac for the supply of nutrition to the developing embryo. Usually the vitelline duct obliterates during the 8th week of gestation. However, it can persist, and this is called Meckel's diverticulum. Usually, Meckel's diverticulum is an asymptomatic condition and can be found incidentally on imaging later on in life. However, the duct can contain ectopic gastric mucosal cells, usually found in the stomach, that secrete acid and can lead to bleeding and ulcers. The duct can also act as an anchor point for the twisting of intestines known as volvulus. So patients that suffer from this are at risk of bowel ischemia and perforation, which will need to be managed surgically. The rule of twos here is useful for exams, to remember important facts about Meckel's diverticulum. For example, it is twice as common in males, and it usually presents around 2 years of age if symptoms do occur. Another patient group at risk of volvulus are patients with malrotation disorders. During the development of the GI tract, the midgut herniates into the umbilical cord and returns to the abdominal cavity having rotated a total of 270 degrees anti-clockwise. If this process occurs abnormally, it can lead to alternative positioning of the midgut organs within the abdominal cavity. It can also lead to formation of abnormal peritoneal tissue or connections between the cecum and the duodenum, known as Ladd's band. Malrotation disorders are usually asymptomatic. However, later in life, if the intestine twists on itself at the point of Ladd's band usually, blood supply can be restricted to the intestine, causing ischemia and potentially bowel perforation and sepsis. This will need urgent treatment with IV antibiotics, IV fluids, and ultimately surgical intervention. So, today we have learnt that paediatric patients are often presenting with non-specific symptoms, and it's important to consider GI pathology as a cause of these symptoms, taking into account their antenatal history, age, and associated symptoms. It's useful to use our knowledge of normal embryological development when understanding the pathophysiology of GI conditions. Early identification, commencement of IV fluids, and keeping nil by mouth with referral to the paediatric surgical teams are key first steps when managing paediatric patients with GI abnormalities. That is the end of this lecture. Be sure to check out simplemed.co.uk for hundreds of free articles, thousands of free questions, and any support with questions you might need. Thank you for listening, and goodbye.